Hi, everyone. Welcome back. Today, we're joined again by Dr. Eddie Stenehjem to give our weekly COVID-19 update to the community. Eddie, as always, thank you for joining us.
Thanks, Amanda.
So I want to start with case trends. Let's just go over the numbers really quick on what's been happening since the last time we spoke. The total case count in the state of Utah is 88,963. Yesterday's reported daily case counts was 1,126 with around a 13% positive rate. We have a total of 527 deaths, and we have a total of 4,460 hospitalizations that have happened throughout this. Eddie, let's break that down. I want to talk a little bit about what that means for the community. And if you're watching this right now, please make sure you turn off your cameras and mics because you're showing up on my Facebook Live. So Eddie, let's break that down a little bit. How are those case counts and hospitalizations impacting our systems right now?
Yeah, not in a good way, that's for sure. I mean, our case counts are continuing to go up. If you look at our average 7-day rate, it's the highest it's ever been. The trend is to continue to go up. We're seeing cases throughout Utah. We're now seeing more cases in Weber, Morgan, Davis County, stabilization in Utah County, Salt Lake County. But we're seeing cases, being spread in the community throughout all of Utah. When we look at the entire United States, we're the fifth highest state in terms of rise in cases. North Dakota, South Dakota, Montana, Nebraska, and Utah. And so, I think the governor kind of, hit it right on the head, saying we're not doing a great job in terms of controlling this pandemic. And that's continuing to be the case. And when you look at how it's affecting us from a healthcare system, hospitalizations have gone way up. We now in our Intermountain Healthcare Network have had more cases today for COVID-19 than we ever had. We're over about 40% higher than what we were back in July. And we're load leveling like we've never done before. We're transferring patients. All our large facilities have, very considerable case counts of COVID-19. This morning on our tele-COVID rounds, we had 46 patients at just Intermountain Medical Center that are admitted, hospitalized, some critically ill and dying from COVID-19. And then when you look in our other hospitals, our larger facilities, St. George, Dixie Regional has 31 patients. Utah Valley has, 30 patients. This is getting to a point where, we're going to be opening up overflow ICUs and we may have beds that take care of these patients, but our staff is getting incredibly tired and short, and we're ICU nurses are working around the clock, and so this is getting to be a very critical point for us in this current surge.
We haven't really seen our case counts go down in the last couple of days, or even our positive rate. Is there anything that you can contribute that to specifically? Do you feel like it's schools or just gatherings, or what do we think is causing this community transmission right now?
Yeah, and so, I mean, when you look at the demographics of our positive cases, what we've seen is the 15 to 24-year-old age group is improving. We're having decreased case counts. Hopefully that's just not decreased testing in that age category, but we're seeing decreased case counts, and we're seeing an increase in case counts in the 25 to 44 and 45 to 64-year-old groups. And the challenge with that is that the 45 to 64-year-olds, those are the ones that are predominantly making up our hospitalizations, in addition to the 65 and 84-year-olds kind of being in second place. And so we can't necessarily attribute it currently to schools. That 15 to 24-year-old age group had that first spike. Hospitalizations didn't go up because that group has typically milder illness. Then they transmit that to parents, and then parents into the community. So what we can say is that this is ongoing community-based transmission of the virus, leading to pretty severe illness in a lot of people.
I just want to ask a quick clarifying question that we just were asked. Is this 31 patients added in the last 24 hours at places like Dixie Regional, or are we reaching that total of around 31 patients in our ICUs?
Yeah, that's just a hospital census of COVID-19. So those aren't people that were added today. Those are how many people are in the hospital for COVID-19 at any one time period. And they may have been there for 2 weeks. And we should mention, like, that's the problem with COVID-19 is many of these patients get admitted and they're in the hospital for a long period of time. You know, it's not a quick admission where you can turn these patients over and get them out so new patients can come in. That's a huge challenge of people that have severe illness with COVID-19 is that many of them stay in the hospital for weeks, especially those that have severe illness and require, to be on a ventilator.
We've always talked about this too, that it's not really about the beds, but about the people. I know there was a story last night about someone who was looking for an ICU bed and waited about 2.5 hours for that bed, which is crazy. And it just shows how severe this is getting to become. And I want to talk about something that's been circulating around herd immunity and just reiterate what herd immunity actually is and what we would actually have to do as a country, even the world, to achieve something like that.
Yeah, so herd immunity is when the community develops immunity at a level of about 80 to 90% of the community being essentially resistant to an infection. Okay, so take measles, for example. Measles, when you get vaccinated, it's a very effective vaccine, and the vast majority of the public has had the vaccine. So we have immunity levels in the community of about 95%. So that means even if measles came into the community, it can't spread because it can't find people that are susceptible to that infection. Okay, so trying to transfer that to SARS-CoV-2. Well, we know that only 10 to 20%, depends on where you are and what population you look like, have antibodies to SARS-CoV-2. Okay, so that's one, or way low in terms of needing to meet that threshold for herd immunity, which is, upwards of 60, 70, 80%, depends on who you read and what they're saying. So we're way below that. And what should be really emphasized is that if you get the infection, that doesn't necessarily mean you have long-lasting immunity. And so just like other coronaviruses, seasonal coronaviruses, that immunity is likely going to wane. And so if you go ahead and, let's say, get infected, you may be protected for a period of months, but you does not mean you've got long-standing immunity for reinfection for SARS-CoV-2. So that tells you that, if you're decreasing your immunity and you become susceptible again, we can't generate herd immunity by having everybody get infected by SARS-CoV-2. The only way we're going to do that is if we develop a vaccine that has long-lasting immunity. And so there's been some proponents at the national levels focusing on herd immunity, which when you look at it from a scientific basis is so off base and is just going to lead to more and more people getting sick and our healthcare system being overwhelmed. I mean, look at what's happening right now. We're not anywhere close to having herd immunity, and our hospitals are getting full to the point where we're opening up units. And this is with, pretty significant, masking guidelines and those types of things. So, if we open things up and let communities go and, protect our vulnerable populations, which some people say, we would see devastating consequences in the hospital and our healthcare networks and to the health of the population.
You mentioned this reinfection piece with herd immunity, and someone just asked a question about your thoughts on reinfection. There's been a couple of cases in the news of people thinking or the hospitals thinking they got reinfected with COVID-19. Do we have any sort of evidence or data yet to support that that is a possibility and something that could happen?
Yeah, so there's now a number of cases in the literature of definitive examples of reinfection. And so how do you make that determination is that you look at the virus that you got infected with first and you sequence the genetic code, and then you get reinfected again and you take a look at that virus and look at that genetic code, and you can determine if those are different viruses based on mutations in the genetic code. And so you really have to do sequencing of the first virus and the second virus to see if they're different, because we know that there's plenty of people that have just this long kind of period where they're just shedding viral RNA. But there's clearly examples in the literature of people, truly getting reinfected with SARS-CoV-2. We do not know, what is the duration of protective immunity. That is something that we just don't know yet. There likely is some level of protective immunity for some period of time. And it likely is also dependent on the severity of illness on your first infection. And so can it happen? Absolutely. Do we think that there's some level of protective immunity after infection? Yeah, we do, but we just have no idea how long that lasts. It's probably going to be on the order of months and not years.
Quick question for you. We haven't really introduced you in a while formally to people, and we just got a question on what you're basing your opinion or thoughts on. Can you just give your credentials and kind of how you've been involved with COVID-19 infectious disease to begin with from the start of this?
Yeah, so I'm an adult infectious disease physician. I trained in ID at Emory University, where I also got a master's in clinical research and epidemiology. And I am now been with Intermountain since 2012, and I'm the medical director of antibiotic stewardship for the health system, and have been very actively involved in a number of our COVID-19 preparedness procedures and protocols, and also am one of the COVID-19 ID rounding doctors, where we round on all the COVID-19 patients throughout the system, make sure they're on state-of-the-art therapeutics and clinical trials as necessary, and assist the ICU docs and the hospital medicine physicians as well.
Thank you. Much appreciated. I hope that clears up where you're giving or why you're giving us these updates every week. I want to talk about a guideline that was updated. I think it was Friday of last week, but the governor came out with new guidelines around school quarantine, specifically stating if your child is in a quarantine for 7 days and was wearing a mask and can produce a negative result at that 7-day mark, they can go back to school. This is a little bit different than the normal 14-day quarantine we've been seeing. Do you think this is a good idea? What are your thoughts on this? I know you alluded to it a little bit last week, but let's just walk through what that means.
Yeah, so I think we should be really clear in the fact that this applies to students that have been exposed to a positive individual. Both of the individuals are masked. And so masking we know lowers the transmission rate, but they were a high risk individual, meaning that they were within 6 feet for greater than 15 minutes. If those things can be, determined to have occurred, meaning they're both masked and they're still a high risk individual, that exposed, student will get a test at 7 days. And if that test is negative at 7 days, then they can return to the classroom. The reason that this is, important is, it essentially halves the amount of time that the student has to be home, which has so many implications, right? It gets them back in the classroom, gets them back socialization with their co-students, and it potentially allows their parents to get back to work. So it has so many implications. And if you have a negative test at day 7, I do think it's safe based on a number of studies that have been reported, because we know that the median incubation period for this virus is 5 days. Okay, so if you pass that median incubation period and you're now at day 7 and you have a negative test and you continue to be masking in school, the rate of transmission is incredibly low. But it's really contingent on the fact that you have to have a negative test at day 7.
So to clarify, does that mean that you should get tested on day 7 and then wait for the results before you go back? Or if you're tested on day 7, does that just mean you can go back?
No, absolutely. You have to be tested on day 7 and have a negative result. And so, average kind of turnaround time across the state, as Dr. Dunn mentioned, is 48 hours. And so really, you're probably getting back more like day 9 than you would be at day 7.
I want to talk a little bit more about the guidelines, specifically about the announcements of yesterday's guidelines that the governor went over. We're moving into this high, moderate, and low phases as opposed to the color coding. And I just want to break down what that means for us as a healthcare system and our hospitals. The high category requires masking, and a lot of the moderate category does as well. But will you break down how this could potentially help the healthcare system as we move forward?
Yeah, so this is, moving into some statewide guidelines that are basing your level of transmission risk on a number of metrics. And those metrics are the 7-day average percent positivity, the 14-day case rate, and then the statewide ICU utilization. And really determining where each county fits in terms of transmission risk. And then each county is reevaluated every 7 days to determine whether or not they increase their profile and going from moderate to high, for example. And only way to go down in risk is if you have 14 days of stability. So you really have to wait 14 days before you can actually come down in a risk category. And then there's a number of public health measures tied to each one of these levels of risk. And the governor and the Utah Department of Health went through some of these, but really, I think that what's most important is that masking is required for any indoor activity or outdoor activity where physical distancing is not possible in the high level category, which is much of populous Utah right now. So Utah County, Salt Lake County is all in the high. And so masking is required in those instances. And it also should be noting that masking is required even in the moderate until October 29th to try to, they use the metaphor of being a circuit breaker, trying to, stop this current surge. And so masking is really important. And then they're limiting social gatherings to less than or equal to 10 people in the high level and less than equal to 25 in the moderate level. Moderate level right now is actually at less than 10 until the 29th, because again, this is a circuit breaker kind of idea. And so we hope that people abide by these guidelines. It's one thing to have guidelines, but if nobody follows them, it does absolutely nothing. So that people actually abide by these guidelines. We see essentially mandatory masking in these communities with high risk transmission, and we see decreasing in social gatherings. And so we're really hoping that these new guidances from the state is actually going to potentially change the trajectory of our pandemic.
You mentioned the less than 10 for social gatherings. There was such a large emphasis on the social gatherings versus public gatherings. Why is there such an emphasis on hanging out with your friends and family in smaller groups versus the general public?
Yeah, so, I don't have the data on this, but the report from the health department and from the state really emphasize the fact that much of the transmission that is ongoing when they're doing contact tracing is that they're seeing transmission in social gatherings, in small casual settings, whether it be family reunions, birthday parties, et cetera. That's where they're seeing a lot of this transmission. And so that's really the reason why they're focusing very intently on that. It should be highlighted though that you can have plenty of transmission of COVID-19 in a social gathering of 10 people. If you host, a dinner party and you have 10 people and you're sitting around a table, there's going to be plenty of SARS-CoV-2 transmission. Let's not kid ourselves. But what it does is it limits the amount of spread to just those 10 people. And so you're decreasing the potential transmission in the community versus having 25 or 30 people over where maybe now you're infecting 15, 20 people instead of just a handful. So I don't want people to get this false sense of security saying, oh, it's okay for me to have a social gathering unmasked in my home with 10 people. You really still have to consider, your risk and the risk of people that are coming into your house, because you can still have transmission within those 10 people. It's just that you're not going to potentially transmit the virus to wide swaths of people that you're gathering with.
Two quick questions that just came in. The first one is about our immune systems. This question says, since we're all essentially in isolation, avoiding public gatherings, avoiding most germs that we would normally allow into our immune system, is this detrimental at all to our immune system for diseases other than COVID-19, this period of isolation we've been in for 7-8 months?
Yeah, it's a really interesting question. I would say in the short term period, no, absolutely not. I think what will be really interesting to look at is the effect on really young children that were essentially born into this pandemic. And these young children now, I'm thinking about my 6-month-old son that was born in March when we just were getting into this pandemic and has not been exposed to very many people at all, hasn't had any URIs. And so, I think it'll be very interesting to see what happens to this cohort of kids that gets through their first couple years potentially with very minimal URIs or exposures to viruses. They're still getting exposed to, antigens in the dirt and in the, community from their parents. It's really that they're not being exposed to viral pathogens. And if that will have any impact moving forward on whether it be autoimmunity, disease states, allergies, et cetera, that's the part, we don't know. I think from an adult and adolescent standpoint, we've, seen so many different viruses and bacteria that this temporary kind of reprieve from new viruses being seen by an immune system, I don't think that's going to have any impact at all. I think it's really going to be interesting to look at that young cohort that are really protected.
So it's something we probably won't learn more about until the future. But obviously it sounds like you guys are looking into stuff like that. One other question that just came in too is we've heard from readers who are parents whose child are in a group setting and were exposed to a positive individual. They were told that their child doesn't actually need to quarantine because they were exposed to them for 14 minutes and 30 seconds, which is less than that 15-minute mark. Is this a valid assumption that they should not be quarantining at all?
So the CDC and others have had to make some determination of what is a high risk exposure. And they came up with 6 feet, which is great because that's, really identified in science as being the high risk zone based on droplet transmission and time, so is there a difference between somebody being exposed for 14 minutes and 30 seconds versus 15 minutes and 30 seconds? Probably not. I think you really have to kind of take that into consideration and really say, what is our risk as a family and in our community? And maybe you have somebody who didn't meet the definition of a high risk exposure because it was, 14 minutes and 59 seconds, for example. You still may want to quarantine especially if you're, a high risk family that have high risk, individuals in your home, or you interact with people that are of older age or immune compromised. And so I think you really have to kind of, take that advice and then internalize it for your situation that you're currently in.
Another question I wanted to ask you about was a report that the CDC came out with last month around dining in. It was reported that adults that had confirmed COVID-19 were almost twice as likely to have dined in at a restaurant within the last 14 days of becoming ill. If we're having these social distancing measures and mask using implemented, it seems like it's not being as effective when you're dining in. You walk in, you're wearing your mask, but you immediately take it off. How do people go about this whole dining in experience? Is there things they could be doing instead of dining inside at a restaurant, or what are your recommendations for that?
Yeah, so this is, again, a personal decision based on your risk profile, right? So a restaurant, let's say a traditional indoor restaurant, has typically lots of people. It's generally loud, so you're speaking loudly. And you clearly are not masked because you have to eat. And so there's definitely risk there. And I think the CDC reports is just kind of highlighting that. In the new guidelines put out by the state, they do make, recommendations for indoor dining for high, medium, and low settings, with high focusing on there has to be 6 feet of distance between parties, and there has to be 6 feet of distance between people waiting for tables, for example. And so they're doing the best they can to potentially mitigate spread by really focusing on wearing a mask while you're waiting And then when you're at your table, you're at least 6 feet away from other parties. And so they're doing their best they can to minimize that, and to be able to keep restaurants and dining establishments open, which are a huge source of employment for lots and lots of people. And so I think that's good. But at the same time, you know that this is an indoor location. Maybe the ventilation isn't great. And, you know, if you're a high risk person, then you should choose not to go to a restaurant. And definitely support our local restaurants as much as you can through their, you know, dining out options, and, you know, calling ahead and get it to go, or look for restaurants that you can, you know, dine outside, which definitely we know reduces transmission. And so I think the fact that we've seen transmission in restaurants is, you know, something we expected, and it's just based on what's the restaurant doing to decrease that risk, and what is your risk for severe disease at baseline.
And along those same lines too, I just have a follow-up question around the new guidelines. Do you think that these new guidelines are going to help limit the transmission between people and potentially cut down on the number of people being hospitalized?
Only if people follow them. I mean, it's as simple as that. If people followed these, absolutely. I have no doubt that we would see a positive impact on our epidemic. We'd see counts come down. We'd see hospitalizations stabilize, and we'd be in a much better spot. But people have to follow them. You know, people actually have to wear masks and wear them appropriately and limit their gatherings. And so, you know, absolutely they'll help as long as people abide by them.
You mentioned wearing a mask correctly. Will you just reiterate what that actually means? I know I still walk into lots of places, the grocery store, wherever I need to quickly run an errand, and people are not wearing them properly, which makes me feel really uncomfortable. And I try to get in and out as fast as I can. But will you just explain what wearing a mask properly means?
Yeah, I mean, the biggest thing is that the mask is covering both your nose and your mouth. And so, I mean, we all have seen so many people with the mask, you know, right below the nose. Turns out we go to the nose to look for viruses. And so when you breathe in out of your nose, that's where the viruses come out. And so you just have to be wearing it over your nose and your mouth. And it, you know, it's actually, you just can't mess with it, you know, can't fidget with it, take it off, take it on. I see, you know, a lot of people, you know, take the mask off to speak. You're like, that's so counterintuitive. You just have to wear the mask over your nose and your mouth the entire time. And, you know, with practice, this becomes kind of second nature, and it becomes a lot more comfortable, but you just got to wear it appropriately.
It's good advice. And I know that it can be difficult to not touch your mask, but I've kind of gotten the habit to like not even bring my phone into a store, because
Right.
I feel like I'm more likely to touch my face or whatever if I'm playing around with the phone. So I bring as little as possible into the store, so that way I don't actually have to potentially carry around the virus, which brings my next question. The CDC came out with a report around the virus potentially lasting 28 days on surfaces. And I don't want to touch on this a lot, but briefly, what have we learned from that specifically? And is it the actual virus that you can contract, or is it pieces of the virus? How is that report working?
Yeah, I think, you know, from the reports we've seen, the vast majority of transmission of this virus is through the respiratory tract, and it's through droplet particles, and occasionally, in the right situation, aerosolization of the virus. That is the predominant form of transmission. Fomite transmission, where a virus is on an inanimate object, you touch it and then touch your face, likely does contribute to some transmission, but it's probably pales in comparison to the transmission seen from a respiratory transmission pathway. And so, you know, the idea of washing your hands, not touching your face, not touching your eyes, absolutely supportive of it. But the predominant form of transmission is through the respiratory pathway. And so the CDC reports saying that they found virus on surfaces for over 20 days after, you know, exposure. That means that they were able to find RNA from the virus. Okay, that does not mean that that virus that they found on that surface can transmit the infection. That just means that they found RNA of the virus on that surface, but it does not by any means say that it's transmissible. And so I think the current guidelines of focusing on masking and controlling respiratory transmission is still 100% in play. And that, yeah, we should be washing our hands. We should be potentially covering our eyes, especially in healthcare settings where we potentially could get respiratory droplets in our eyes. But the predominant method is through respiratory pathway, not as much as through contact surfaces.
Another report that recently came out, or not report, but information, the WHO came out and said that they did not support lockdowns anymore, saying that it was doubling the world's poverty. And they were saying lockdowns should be the last resort and something that helps alleviate our healthcare workers. If we're not having these lockdowns or staying home, what are some other ways that we can keep ourselves safe? And I would like to say that I don't think Utah is in a state of lockdown at all. People are definitely living their normal lives, but if you're not staying home, how do you keep yourself safe and you do have to go out and about to run your daily life?
Right. I mean, I think the WHO came out with that, and I think it's very reasonable, right? Lockdowns are very extreme measures, essentially house arrest, right? You're only going out to the grocery store. And that has such huge downstream effects on our community and mental health that should be used as a last resort. Right. So that means businesses close, schools shut down, people are trying to work from home, people are shuttered, elderly can't visit, with their family. And the toll that takes on our economy and on our mental health is just cannot be understated. So I absolutely agree that a lockdown is absolutely the last resort. And we use that as kind of a ripcord to say, hey, we are under massive strain in a hospital. We cannot take care of patients regardless if they have COVID-19 or an MI or in a trauma. That's when you have to kind of revert to that. And so we want to make sure that we protect our community so we never get to that state. And the way we do that is through these public health measures, right? The way we do that is limiting the contact we have with others. That's not the same as lockdown, right? That's social distancing. That's giving 6 feet between individuals. That's limiting your indoor gatherings. That's limiting any large group gatherings, and wearing a mask. So we do all of these things that we've talked about, limiting social gatherings, wearing a mask, washing our hands, to prevent our communities from getting to the point where we have to do a lockdown, because the lockdown has such detrimental effects on the communities and the economy that we just don't want to go there if we don't have to.
A question for you too on vaccines. Johnson & Johnson just announced that they were pausing their vaccine trial due to a participant exhibiting an unexplained illness. And you also mentioned before this call that they're also, another system is also pausing a trial that they had in place. Will you just give us an overview of what that means, and also if we have any sort of update on a vaccine?
Yeah, so Johnson & Johnson vaccine trial using an adenoviral vector started a number of weeks ago now. Just got a report that study was paused because one of the individuals had an unexplained illness. Keep in mind that happened also with the AstraZeneca trial that is in the US, UK, South America, and Africa. That also got paused because of in a case of transverse myelitis, and then a second case as well, and that hasn't restarted enrolling yet in the US. This is just good science. So this is what all of vaccine trials do, regardless of whether or not we are in a SARS-CoV-2 pandemic. This is what happens when you give thousands of doses of vaccines to a population. Some people are going to get sick, and it's the job of the trialists to understand if that illness could potentially be related to the vaccine, and that takes some time. And you don't want to be continuing to enroll people if there's a potential signal of harm. And so them reporting out that they're pausing the trial, whether it be J&J or AstraZeneca, this is good science, this is safe science, and this is to be expected. Studies start and stop or pause, all the time to allow the investigators to investigate, to make sure that they're not having any kind of signs of adverse events. And so this is actually very reassuring that the pharmaceutical companies are abiding by, good, sound clinical trial principles. And then the other trial you mentioned is a trial called TICO. It is studying a monoclonal antibody to essentially treat people with COVID-19 that are hospitalized. So this is the same type of therapy that President Trump got. He got the Regeneron monoclonal antibody cocktail. This study that was paused is done by Eli Lilly. And again, same kind of deal. They're pausing, taking a look at that data to make sure that they're not seeing any safety signals, and then we'll restart once it's determined that it's safe.
I think it's important, just on that note too, most vaccines don't take 6 months to produce, they take years. So the fact that, like you said, these companies are taking a pause and looking at the data is really great for the general public. It gives you some sort of security that these companies are caring about what the vaccine is doing to you and what it'll do to the future. So I think like you said, it's a good sign. Maybe it's not the sign people want, but it's definitely helpful. My last question for you is around the flu vaccine and just COVID-19 in general. We're getting into this colder weather. It's starting to get a little colder here in Utah, and the flu is definitely coming up quickly. I got my flu shot last week. Why is it so important for the public to get their flu shot? And what do they need to know, if anything, about the flu this year?
Yeah, so if you are ever to get a flu shot, this is the year to do it. We know that, every flu season, so really kind of starting in December, January, February, March, tens of thousands of people will get influenza. In general, between 20,000 and 60,000 people die from flu each year across the US. This is preventable. And so the flu vaccine will decrease the severity of influenza. It's not perfect. It may not, prevent influenza in all people, but it will reduce the severity of influenza in a large portion of the population. The reason that's so important is that we are currently in a surge, and we anticipate that cases will continue as we get into the fall and winter. And whatever we can do to decrease the burden on our hospitals is something we have to prioritize. And so what we can do is we can get flu shots to reduce the chance of getting severe flu, which would require hospitalization. And so we really need to focus on that preventative therapy. We have no idea what the influenza season is going to look like. It actually was a pretty muted influenza season in the Southern Hemisphere, but that was due to the very strict public health precautions that have been put in place in those countries. And we hope that we have a very similar kind of muted response, but we have no idea. Keep in mind that mask wearing and social distancing limits the spread of influenza. It limits the spread of rhinovirus and all the other respiratory viruses as well. In addition to SARS-CoV-2, the virus causes COVID-19. So these public health measures that we've put in place, in addition to flu vaccine, we hope would really kind of mitigate any kind of severe flu season that we'd potentially see.
And for everyone watching, you can find out where to get your flu shot at intermountainhealthcare.org/flu. There is a list of public flu clinics that are happening that are drive-through. They're very easy to go to and very simple. You can also get your flu shot at your scheduled appointment with your provider as well. Eddie, is there anything else you wanted to mention today around COVID-19 or how the community is doing?
Yeah, I think just to reiterate, our hospitals are under stress right now. We've never seen this many patients. Our healthcare workers are doing an amazing job. And our ICU docs, our nurses, our pharmacists, our respiratory therapists, they are the true heroes in this. And whatever you can do, not you, Amanda, you, the general public, whatever you can do to really mitigate any kind of transmission is going to be so appreciated. Everybody has a role in this. This affects our entire community, and everybody needs to contribute. And whether that be, always wearing a mask, reducing your exposures, we need help. And the time to act is now, because we're not seeing any change in this curve at all. So I would really kind of take the time and think about, what are you doing personally to help the community? If you're not wearing a mask, if you're going out touting the fact that masks don't work, that's not helping. If you don't want to wear a mask, great. Don't wear a mask. Just don't go out then. Then do social distancing, stay home. If you don't want to wear a mask, just do something to help us. And those things are really clearly laid out in the new state guidance. We just need people to follow them. Otherwise, we're really headed down a pretty scary road.
Great advice. And I think it's also important to note that this is just 1 year. And yes, this might go longer, and it probably will. But in the grand scheme of things, helping us now is probably going to help your life return to whatever your normal was before. So whatever you can do, and I will do it too, make sure you do that. And if you guys have any questions around COVID-19, you can use our online symptom checker, which is located in the bottom right-hand corner of our website at intermountainhealthcare.org. It's located on any of our pages there, and it'll run you through questions related to symptoms, exposure, and let you know whether you should go get tested or not. Eddie, as always, thank you so much for talking with us, and we will talk with you next week.
Thanks, Amanda.
Bye.